Welcome everyone to Endoscopy Now and today's virtual education series, Freeze Disease, Managing Complex Esophageal Neoplasia with Liquid Nitrogen Spray Cryotherapy. I'm Whitney Swamy, and I'll be your moderator for today's virtual ed discussion. Our speakers for this session include Dr. Tufik Achami, the Interventional Program Specialist and Chief of Medicine at City of Hope in Phoenix, Arizona. Dr. Tilak Shah. Dr. Shah leads the Multidisciplinary Pancreas Center as the Medical Director and Staff Specialist in the Department of Gastroenterology, Hepatology, and Nutrition at the Cleveland Clinic in Weston, Florida. Dr. John Vargo is the Director of Endoscopic Operations and the Director of Endoscopic Research and Innovation at the Cleveland Clinic in Cleveland, Ohio. And our physician moderator for tonight will be Dr. Neil Sharma, the President of the Parkview Cancer Institute in Wayne, Indiana, Chair of Upper GI Tumor Site Team, the Program Director for the Advanced Interventional Endoscopy Fellowship at Parkview, and the Director for Interventional Oncology and Surgical Endoscopy Programs and Assistant Professor of Medicine at Indiana University. Welcome to the speakers this evening, and thank you for joining us today. Dr. Sharma, thank you for leading this discussion this evening.
Winnie, thank you for the kind introduction. I'm really honored to be joined by an absolutely all-star cast of individuals I've had the opportunity to work with on research or listen to lecture or read their work. And I think you'll really enjoy our program this evening. You'll get a diverse array of applications of spray cryotherapy. So whether you've never seen the technology before, or if you're a medical oncologist or surgical oncologist, perhaps this may be part of your armamentum for your patients. For those practicing and already using cryospray therapy, this will be a great opportunity for you to hear more about future applications. So without further ado, we'll jump right into our lecture. So the lecture objectives, I'll be talking about an overview for cryoablation applications, which can expand your practice. I'll give an introduction to cryoablation and talk about some tips and tricks, which will get further highlighted throughout all of the speakers this evening. All of us have tried to incorporate at least one research highlight, which may be unique to cryoablation. I'll be speaking on the safety of cryoablation with the use of anticoagulants. Dr. Kachami will be talking about the palliation of malignant dysphagia and give a case highlight. He'll also talk about more aggressive treatment intervals, and they'll have a research highlight on cryotherapy's impact on quality of life in inoperable esophageal cancer. Dr. Shah will be talking about early esophageal cancer management with a case highlight. He'll also have a research highlight on changes in the microenvironment with liquid nitrogen therapy and chemoradiation in locally advanced esophageal cancer. Finally, Dr. John Vargo will be talking about a case with squamous cell carcinoma of the esophagus, highlighting the use of spray cryotherapy as a salvage therapy, and then go over some pearls and key takeaways for you this evening. For the first portion of the lecture, we're going to begin with a question to engage all of you and get a better sense of our audience. So the first question of the night, are you using liquid nitrogen spray cryotherapy in your practice? Simple answer, yes or no. I'll give a little time for the audience to respond. Okay, let's take a look at the survey results. So it looks about 50-50, which is perfect. So some people will be completely novice to this type of technology or not utilizing the technology. Perhaps they're not an endoscopist, which is completely fine. And then others have some experience with it, which is great because it'll allow us to highlight some of these novel research and innovations that we've been working on through our clinical research. So an overview of cryoablation technology. This is a great introduction into the technology itself, how it's utilized, its safety, efficacy, and application. So the TrueFreeze system utilizes liquid nitrogen as a cryogenic agent, which boils at -196 degrees Celsius atmospheric pressure. Liquid nitrogen has been used for decades, and it's been used in a variety of cancer modalities to treat malignant and benign tissues and lesions. Liquid nitrogen, when applied to human tissue, causes direct cell injury by intra and extracellular ice formation. This leads to cellular death really as the tissues thaw. So the work is happening not when you're spraying, but as the tissues warm back up. Unlike heat modalities, liquid nitrogen kills cells and maintains the extracellular matrix, resulting in normal regrowth and minimal scarring of those tissues. So when you go on to biopsy them, the architecture is preserved for the pathologist. Here's what the console looks like, and there's been many reiterations of this device as we continue to incorporate new adaptations by STERIS, who've really allowed us to have new catheters and different ways to apply the spray cryotherapy. These slight modifications have improved our efficacy and safety of the procedure. Here you can see the spray catheter, which goes down through the channel of a regular upper endoscope, or it can go through a neonatal scope, which will be highlighted later. There's a tapered introducer, and there's a 20 French cryo decompression tube. This was the original tube. There's now a 16 French decompression tube as well that can be utilized depending upon the anatomy of the patient. And then cryogen, which is stored within the console. So what do the steps look like for the procedure? This is a nice general overview. First, we target the identified ablation area that we hope to apply spray cryotherapy. Next, we're going to turn on suction. So we've actually put the catheter down into the abdomen of the patient, going through the esophagus and deploying the catheter below the GE junction into the stomach. There's a fenestrated catheter, and then we touch suction immediately. We then place a catheter through the working channel using that introducer that was highlighted previously on the slide. We then cool the console and begin cryospray by holding down the blue pedal. This is held the entire time. When you take your foot off the pedal, it stops the spraying of cryotherapy. Then we start the timer, and we really want to start the timer once the entire area that we're hoping to target has turned completely white. Not prior to that, otherwise the dosimetry is off or manipulated. A typical dose may be 2 centimeter for a 2 centimeter area, might be 20 to 30 seconds with freeze and thaw cycles. So what that means is you deploy spray cryotherapy for 20 seconds and then allow it to thaw. And you might do that 2 times. Again, you may use 30 seconds 3 times. As you'll see highlighted in the lecture, we've really played with the dosimetry to fine tune and get the results that we want. And one thing that I really like about the technology is it's very much operator dependent. So while that may have some cons in terms of the dosimetry and how it's deployed, for those who get facile with the technology, it really allows us to manipulate the dosimetry to get the targeted clinical outcome that we hope to achieve in the patient. One other thing that's really unique is we can actually manipulate the endoscope and flex it backwards. So we can treat areas of the cardia that may be more difficult to treat when you're going on FOSS with other types of technology. I would like this slide because you'll see highlighted throughout tonight, we're talking about esophageal neoplasia and esophageal cancer. So it's good for us to understand the anatomy so we can better understand what it is that we're hoping to target and treat. High-grade dysplasia, by definition, is not going beyond the surface epithelium. Once we're going into the basement membrane and lamina propria and to the muscularis mucosa, we're into intramucosal carcinoma. If we're going into the submucosa, that becomes a T1B submucosal cancer. T2 means that there's invasion of that muscularis propria. T3 means it breaks beyond the muscularis propria. Remember, the esophagus does not have a serosa, so it goes into the adventitia. T4 means it's going into adjacent structures. And now, based on AJCC staging guidelines, T4 is broken out to A and B, B going into vital structures, making it completely non-resectable, A going into non-vital structures, allowing for future resectability potentially after a neoadjuvant approach. This is another really nice diagram that better illustrates the depth of penetration that's involved based upon the type of treatment that you utilize. So some people who are already using RFA, which is a technology that we use, radiofrequency ablation, to treat Barrett's esophagus, may be familiar with its depth of penetration, limited really to the lamina propria. RFA is a thermal energy, so when it destroys cells through heat, you naturally will create an impedance as those cells are heated up and then they undergo apoptosis. They have a resistance to current called impedance. Cryoablation does not have that type of thermal energy, so it actually has a greater depth of penetration, can penetrate deeper, depending on the dosimetry that could go into the superficial or even deep submucosa, or in some cases, perhaps the muscularis propria. EMR and ESD depths can go down to the muscularis propria, are not intended to go through the muscularis propria. And surgical depth, when you have a total excision through esophagectomy, obviously is a full thickness depth of penetration. Some tips and tricks. So again, we're going to highlight this for you. I'm joined by 3 amazing experts who've utilized this technology in a myriad of ways for clinical applications. So they're really going to expound on this later on. But we start at the basics. For those of you, the 50% that are already using cryoablation, there's 3 things that I can teach that I teach our advanced fellows all the time. Number 1, you need visualization. If you don't know what it is that you're targeting, it's going to be really hard to make sure that you've totally coated those areas of tissue with the cryo spray in order to get the best efficacy. So you want to clean off any water in the channel. We do that through an eccentric syringe. That syringe is then, after you have the introducer placed into the channel of the scope, you're able to spray 2 or 3 times, just air, cleaning out any saliva that may have been accumulated or any water within the channel. The length of the probe must be optimized. And you'll see a couple of videos, one from myself and one from Dr. Vargo, that looks at that optimization. You don't want it too far out, otherwise it'll be too far away from where you're able to see, and you won't have as much control because you're really controlling not the catheter, but the way that you're deflecting the tip of the scope or moving the scope itself. And then we utilize a cap. The cap allows us to not get blowback onto the lens. So that really improves visualization. Next, applications. So I use a cupping technique. I was trained at University of North Carolina for my advanced fellowship, and Nick Shaheen had spent a lot of time with me, and we talked about cupping, which means going 180, going back and forth, making sure you're not stopping. This is a really operator dependent type of treatment. So what you want to do is move back and forth in almost a cup-like motion, treating 180 and then treating 180. You don't want to really stop because you don't need that catheter to touch onto the mucosa surface. If it does, sometimes it can stick there. Additionally, you really don't want to start the timer until you see the white. You really want to make sure you're seeing everything whited out that you're hoping to treat. And then finally, dosimetry. By increasing the number of cycles, the length of the cycle, and or the interval between treatments, meaning you can bring a patient back every week, or you can bring a patient back every 8 to 12 weeks. All of this affects the dosimetry and therein affects the clinical efficacy of the procedure. Tonight, we're going to highlight some unique applications of cryoablation. So if you're already performing RFA for Barrett's, some people may ask the question, do I need cryoablation? Well, if you have a robust practice and you're taking care of not just Barrett's, but esophageal cancer patients, there's some unique applications you can see on the screen. These will be re-highlighted later on at the end of our lecture by Dr. Vargo. One big thing is high-risk anticoagulation patients requiring ablation. Some patients cannot be bridged. For example, I have a couple of patients with mechanical aortic valves. They are very high risk. They've already had a thromboembolic event, and they're asked not to stop anticoagulation, but they may have lower high-grade dysplasia from Barrett's, or even in one case in esophageal cancer. We can treat those patients without stopping any anticoagulation. Next, salvage ablation for those patients who may fail RFA. There's a greater depth of penetrance with cryoablation. Number 3, adjuvant treatment post-EMR or resection, even with ESD, for high-grade dysplasia or early esophageal cancer. That tissue can often be very lumpy and bumpy. We don't want to treat that with RFA. We can bury tissue. Treatment of residual Barrett's after treatment of esophageal adenocarcinoma. Palliation for dysphagia will be highlighted by Dr. Kachami. Salvage treatment for local esophageal adenocarcinoma and esophageal squamous cell carcinoma, which will be highlighted by Dr. Vargo. And then potentially adding to neoadjuvant or redefining a treatment paradigm, which is really exciting research that's being highlighted for you tonight by Dr. Shah. So one quick video for the end of my section, and this video is self-explanatory, but for those who have not seen cryoablation, you'll see me walk you through a case. So this is cryo spray done on a patient with Barrett's esophagus that had some focal high-grade and low-grade dysplasia after being treated for esophageal cancer. This is a patient with a 72-year-old T2N0M0 esophageal adenocarcinoma. He's 15 weeks out from chemoradiation, was not a candidate for esophagectomy due to other comorbidities decided by our head of thoracic surgery at IU. At 8 weeks, he had slight uptake on a PET scan at the GE junction. EG with biopsy showed some residual low-grade and high-grade Barrett's. We already know that this Barrett's will have a natural tendency through its biochemistry to turn back into esophageal cancer. So we want to treat this to keep this patient in remission from esophageal cancer. Here you're seeing a wire going down, and then the suction tube that I showed you earlier going into the stomach. There's 2 black lines that go below the GE junction. There's fenestrations on the suction tubing. Then we'll pull the wire out and attach it to active suction. It's very, very important to ventilate actively throughout this procedure. Remember that every time you're spraying liquid nitrogen, for every 1 ml, that turns into up to 700 ml of gas. So you need to get that gas out to avoid any complications to the patient. So that's where the suction is very important. Here you're seeing some of that cupping technique. I'm going left and right, back and forth in that 180, trying to avoid direct contact to the tissue. You can note the amount of catheter that's actually out past where that cap is on the end of the scope. And then after we're done with one application, we're going to pause here and we're going to allow the tissue to thaw. The thaw cycles are constant at 1 minute, but the spray time can vary anywhere from 20, 30, even 45 seconds. And some of that, again, will be highlighted in aggressive treatment regimens that are better defined by Dr. Kachami. Here you're seeing the second treatment. This patient is actually on Coumadin and aspirin, and we did not stop it for this procedure. Here again, you're seeing the thaw, you're seeing some beefy redness, and I really look for that. I like bleeding in this. I'm always telling my interventional fellows, if they're bleeding, that's a good thing, because that means that when they're thawing, we're actually pulling a lot of free radicals into the tissue and allowing the tissue to undergo apoptosis. Then here's the third treatment for this patient. Again, using that cupping technique, active suction going on. I'll sometimes have my nurses actually feel on the abdomen and even sometimes push on the abdomen just to make sure that there's not over distension of the abdomen itself. And this allows us to have a good understanding of how the patient's doing during treatment. So here's one research highlight for the first one for the evening. This is a publication that's pending publication and has already been submitted. It was highlighted in DDW last year and was an oral presentation. We took a look through 3 institutions at liquid nitrogen applications with spray liquid cryotherapy at 690 liquid nitrogen application events through 3 different institutions, including Temple, Mount Sinai, and Parkview Health here in Indiana. Out of 690 events, you can see 314 of them were continued on antithrombotic therapy. 371 did not have antithrombotic therapy. Leading events that occurred, there were none requiring transfusion, and actually the antithrombotic therapy arm, there's only 3 in those who are not on platelet therapy or antithrombotic therapy. So it's interesting to see how safe this can be. And if you take a look at the breakdown, some patients were on dual antiplatelet therapy, some were on aspirin, some were on a variety of different agents. And what's important about this is if patients traditionally had RFA or even other types of surgical therapies, we often will stop some very aggressive, especially dual antiplatelet therapy or warfarin. This is not needed for the patients. So the patients have less complexity of care, perhaps less cost of care if there's bridging therapy involved, and even your nurses and office staff will be really grateful that this can be continued for the patient. Moving on to the next section, I want to introduce Dr. Kachami. He's going to be talking about palliation of malignant dysphagia with a case highlight, aggressive treatment intervals, and a research highlight on cryotherapy's impact on quality of life in inoperable esophageal cancer.
Thank you very much, Dr. Sharma. It's really a privilege and an honor to join this fantastic panel discussing today the role of cryotherapy. And I want to thank everyone who has taken the time to join us tonight. My task is to talk about spray cryotherapy's role in palliation of inoperable esophageal cancer. So basically, patients who either are too sick to undergo surgery, or they're either stage 4 or T4B that cannot have surgery. I'm going to start by first talking about a case. This is a case that's a lady who's 58 years of age who presented with 2 months history of dysphagia. And she had an upper endoscopy out at another center, and they saw this mass. The biopsies were positive for esophageal cancer at the GA junction, involving both the cardia, as you can see on the right, and the distal esophagus on the left. Next slide, please. She had staging PET-CT, which is typical for these patients. She had cervical lymph nodes, and these were biopsied and were positive for cancer, which puts her at stage 4. Next slide, please. First, I know almost everyone, the audience is familiar with the dysphagia score, 0 to 4, with 0, no difficulty swallowing at all, and 4 being unable to swallow your own saliva. Often patients either carry a cup around to spit in it, or they intermittently can swallow their saliva. And this patient had a dysphagia score of 4. Not everyone is familiar with the EORTC, which is a quality metric that we use. It has 18 questions. We use it specifically for esophageal cancer. It's 18 questions scored from 1 to 4. So the score ranges from 18 to 72, with a higher meaning worse quality of life. So this patient, despite having a dysphagia score of 4, has, I would say, a mid-range quality of life. That metric measures many other parameters more than just difficulty swallowing. Many of our studies look at difficulty of swallowing, but when you look at the NCCN guidelines, the guidelines that the oncologists go by, they talk about when palliating esophageal cancer, you have to make sure you are improving dysphagia and quality of life. So this should be our goal anytime we're treating these patients, is to improve quality of life and dysphagia. Some people go even beyond that when they talk about global quality of life. which is not something we're going to talk about today. Global quality of life include other metrics, including financial impact. And then when you're looking at the treatment, it's important to look at how you're helping the patient globally, not just specifically in the area you're looking at. When we look at stents, for example, they are excellent for dysphagia palliation. But when you look at quality of life, the studies on stents are mixed. Next slide, please. So this is a poll question. I would love to hear the audience responses. So for this patient, what would you do next? This is a patient early in her disease. She's 58, so for sure she's getting systemic therapy. So do you just give her systemic therapy, which is choice A, and hoping that this will improve her swallowing, a stent and chemotherapy, cryotherapy and chemotherapy, or radiation and chemotherapy? If you can enter your answers now. Okay, so we have a diversity of answers. Given this is a cryo session, it looks like many people chose cryo and chemo. Both Neil and Tilak and including myself, did the research on cryo and chemo. Before we started doing research on cryo and chemo, cryo was used mostly in patients who are not undergoing systemic therapy. So we shifted the paradigm to treating these patients earlier. So this patient, next slide now. Based on the NCCN guidelines, all of these are acceptable options. And many times the patient get what is the center, what they are being treated for is most familiar with or has most experience with. And typically what we do is we offer the patients all the choices and then let them choose what modalities, and different patients have different treatments that they prefer. For example, patients who want immediate improvement typically will go for stenting. Patients who have a hard time lying down and sleeping, sitting up, then will not choose stents. If they have a back pain, for example, and say, well, we can't lie down, if you have a stent placed, then they might not choose stenting. Radiation is often something the oncologist will choose because they are familiar with it. And systemic therapy, we know, does improve swallowing, but often not enough to sustain a good quality of life by itself. So next slide. So this patient elected to have cryo and chemo. And one of the questions I get asked frequently is, what is the expectation? How often do you treat the patients? How many cryo sessions they end up getting, depending on their survival and if they're responding to chemo? So I decided to show you a case from the beginning to the end with the dates of when everything was done, to kind of give you an idea, and especially give you an idea of how we evolved with time as we learned how to do cryotherapy and help these patients the most. So this patient presented in February to us. Her original presentation was in December. So she had not received any systemic therapy. On March 15, we gave her the first cryo session, and then March 22nd, a week later, she started her chemotherapy. Her tumor was described as starting at the 29 centimeters all the way to 40 centimeters. But as you can see on the left, the real narrowed areas were at the end. So the tumor involved the upper esophagus from 29, but these were non-obstructing lesions. In her situation, I used a 16 French tube because she had severe obstruction. And typically, I hold the scope and the tube together and push them in to be able to go through the narrowed area, like in her situation. You can see, so from the left to the right, the progression of her endoscopies and her lesions as she was getting both cryotherapy and chemotherapy. So the first endoscopy, 315, you can see how obstructed she is. And then the second endoscopy was 4-5, so 2.5 weeks after. And then 5-2, almost 4 weeks after. And the fourth endoscopy was in July. And you can see that on the cardia, for example, you almost can't see a tumor anymore in the cardia. And the same after the fourth endoscopy, you barely can see tumor in the esophagus. And this is on both chemotherapy and cryotherapy. So this is after 4 sessions. So 4 sessions of cryo, her dysphagia score went down from 4 to 0. Her quality of life score went down from 44 to 21. Remember, 18 is normal. She also had a PET scan on Folfox that showed improvement in her disease. So was cryo that helped her swallowing? It was both, in my opinion, cryo and chemo. Next slide. So this is the clinical course of this patient and what happened next. So three months later on repeat PET CT, there was progression in her disease. So her chemo was changed. At that time, she had mild worsening in her symptoms. So dysphagia score of 1 and her quality of life was slightly worse. It was almost similar to when we started, so 32. We did 1 cryo session in November, a month after her CT showed progression. And this is what we saw. And if you notice on the lower slide, the retroflexion view, you see more tumor in the stomach than you see at the GE junction where we were treating with cryo. And this is a pattern that I typically see with progression of disease. And then after that, she had minimal or no symptoms. She was shifted to Taxol and ramucirumab. And then in January, she had a PET CT that showed improvement in her lesions, including her liver lesions. And she was doing fine, had minimal symptoms at the time. Next slide, please. 3 months later, PET CT shows progression in her disease. And this time, multiple liver lesions and ascites, very fast progression. At that time, she elected to enroll in hospice. She was tired of getting cancer treatment and chemotherapy and procedures. She did request, however, to have 1 cryo session before going to hospice. And this was the appearance of her esophagus. You still see minimal tumor really at the GE junction. And again, that pattern of progression that I typically see in these patients, more diffuse involvement of the stomach and less at the GE junction where we treated. And she ended up dying on the 16th of July in hospice. Next slide, please. So to summarize this patient's situation, from presentation to death, she had 20-month survival. She had 4 initial cryo treatments and then 2 later throughout her disease. Initially, her dysphagia score was 4, and eventually she lived the rest of her life until the end with a dysphagia score between 0 and 1. And then after 4 treatment sessions and chemotherapy, her quality of life by the metrics we use was almost back to normal. And this patient did not require any standing or feeding tube placement before death.
Dr. Kashami, there's a few questions that have rolled in. So if it's okay, before we progress to the next slide, I think it'd be great to answer some of them. A couple of them may have been answered previously just on what you and I have talked about, but I'm just going to give you a series of them. I think they're all kind of somewhat related or around the case to some degree. So one is a question around, what are the sizes of decompression tubes available? And then how do you get an area that's super compressed or maybe even difficult to pass the regular upper endoscope? How are you able to place a venting tube for a nearly obstructing tumor? So those are the first 2 questions.
Okay, so how do we pass the venting tube through a nearly obstructing area?
Right, and what are the venting tube options available?
Yeah, so the venting tube options, there's a 16 French venting tube and a 20 French. In this case, obviously, it was difficult to pass. I elected for the 16 French. The 20 tube French is more sturdy, so it is my go-to venting tube unless I have to use a 16 French. I typically, once I get to the area of obstruction, I hold the scope and the venting tube together and move them forward. So one helps the other move. Often with some torquing and a little bit of pressure, not a lot of pressure, I can pass both through the obstruction. I personally rarely dilate. In the series we published in GIE 5 years ago, we had 1 perforation and it was after dilation. So I personally do not dilate. You can hear Dr. Shah, he has no problem dilating. So it's different people have different preferences. I tend to use a little more force in pushing the tube down together with the venting tube as a unit. And they both help each other move down, lubricating the scope very well. Sometimes I use a XP scope, a 190 XP scope which has a 2.2 millimeter channel. The spray catheter is 2.0 millimeters in diameter. So that allows me to spray even very tight areas. Typically, if someone's esophagus is very tight and the mass is very large, let's say 8 centimeters or 10 centimeters, then I don't usually treat these patients with cryo. In this situation, the top part of her mass was really non-obstructing. So what we needed to do was treat the last few centimeters to allow the improvement in dysphagia. And once you've treated, I sometimes even treat the top. Let's say the patient has 5 centimeter mass. If I treat the top, I can bring them back in a week and treat or 10 days and treat the second part of it if I can't pass completely. But often with the XP scope and a 16 French, you'll be able to pass most strictures.
So that was another question is, and I've had this question asked to me before, which is, if you can't see the main part of the tumor because there's obstruction on the most proximal portion, do you go ahead and treat anyway? And I think you've answered that if you can spray the upper margin, even though you can't visualize distally. I think one thing to point out is you have to make sure that the venting tube, particularly the two black marks, of which everything distal that there's a lot of fenestration, are past that GE junction, past the diaphragm. Otherwise, you won't be able to adequately vent, and that would be the one exception to that. But I think Dr. Kachami answered that question. A couple of questions relevant to chemo plus cryo, since you highlighted that really well in this specific example where this individual got chemo plus cryo. We think, at least based on what you've shown us and what you said, they were synergistic. Do you time them in any specific manner? And if someone's on a combination chemotherapy, is there any risks or anything to be have avoided or special considerations relevant to that?
Yes, I mean, I'll be happy to answer this now. We're going to talk a little bit about it more. I think the best way to do the timing of cryo and chemo is cryo, and then within 24 to 48 hours chemo. That's our current practice, and I'll go over our data a little bit later and why I think that's the case, and also some animal studies as to why we've slowly evolved the practice to do it this way. Also, it's much more convenient for patients, especially if patients are traveling for their care. You know, if you do the cryo the day before and they take their chemo a day later, that's very convenient for the patient. But we do have some data that suggests that proximity in time would be helpful.
Yeah, and I've not found safety to be an issue. So, I mean, you know, ideally, like you said, if it can be planned around the clinical considerations of the patient, travel, how they're feeling around chemotherapy, so on, that's great. But you know, typically people will treat in accordance without really a lot of consideration around safety. The questions are really pouring in. So, Dr. Kashami, in your patient that exhibited the tumor transition, especially in the high cardia, the question was, do you try to treat in retroflexion? That wasn't really shown there. Or do you just continue the chemo regimen and move forward?
I do. Like in this situation, I would treat in retroflexion as well, yes. I don't go treating everything in the stomach. So I treat the area that I think is obstructed. I think it's better to do high quality treatment than to try to treat the entire tumor if we're looking to improve quality of life. Now, if we're looking to eradicate the tumor, of course, you want to treat all of it. But if I'm going to spend, you know, time treating the area that's most narrow, that's probably what's going to give us the most bang for our buck in terms of improving swallowing.
One last question before we move forward, and this was around thermal ablation. So a question from the audience was, thermal ablation like APC, could that be considered as an option?
It can. It is almost all the studies on APC in the past has not shown that it's sustained significantly enough to be meaningfully used. There are some studies that actually, there was one retrospective study that looked at stents versus APC. And that study was very interesting because patients with stent had better swallowing, but patients on APC lived longer, who received APC lived longer. And the patients who received APC required many procedures to try to maintain, and they weren't able to do a better job than stenting. So, you can use APC. There's a very good Cochrane review that compares all these modality, and including chemotherapy, actually, it's specifically in inoperable esophageal cancer for palliation. And they go over APC, and they mentioned the study, which I think when you do ablation, you potentially have other benefits for patients. With that said, that study was retrospective, so it's hard to make really good conclusions from it.
Okay, for the sake of time, we'll continue to move forward with your portion of the talk.
Yeah, so I wanted to talk about kind of we presented this in DEW last year, and we finished the study. Now it has 55 patients. It's being processed for publication. But basically, this was 48 adults. Dr. Shah and Dr. Sharma were part of the study, 5 centers. And these were patients with inoperable esophageal cancer who are also planning to receive systemic therapy. Not everyone ended up receiving systemic therapy. Sometimes patients' preference, sometimes after 1 or 2 sessions, they find that it's not worth their quality of life, and they decide not to have. But all of these patients were planning on receiving systemic therapy, so they were early in their disease. Next slide, please. And these patients received 157 cryo procedures with a mean of 3.3 per patient. And we looked at their quality of life and their dysphagia score after, on average, a mean of 3 procedures. And their quality of life improved with the EORTC 18 from 35 to 28, statistically significant, and the dysphagia score improved from 1.8 to 1.2. Also statistically significant. 86.5% of them were able to lie flat without having heartburn or regurgitation symptoms, which would not be possible if they had a stent placed. Next slide, please. Now, here are some of the questions that I feel are important for technical details and also for the timing of cryo and chemo. So one, we had a trend towards more improvement in patients who had 30-second sprays versus 20-second sprays. This was a quality of life assessment study, so we did not dictate what the treatment of the patient. Every endoscopist did it the way they wanted. So not statistically significant, but seems that 30 is more effective than 20. And also in patients receiving more intensive cryo, which we defined as at least 2 cryo sessions within 3 weeks of each other, which 18 of them did, compared to those who received less intensive cryo. And this is when comparing, again, a 3.3 mean for all of them. There was a significant improvement in their dysphagia, 1.29 compared to 0.17. So if you look at the dysphagia score, the majority of the improvement for the group was driven by these folks who had intensive cryo treatment. So the ones who did not only had a 0.17 point improvement in their dysphagia. The difference between these two were statistically significant, even though our numbers were small. There was also a trend towards improvement in dysphagia when patients received concurrent chemotherapy, when we defined it within 48 hours of systemic therapy. And this is again why we've evolved the practice a little bit to try to do cryo and chemo within 48 hours of each other. With that said, 100% agree with Dr. Sharma. If someone comes 5 days after their chemotherapy needing cryo, do I do it? Absolutely. Next slide. So this is kind of the animal data that started guiding our practice when I started educating myself more and more about the biology of cryo. If you look, these are actually from lung cancer cells implanted on the back of mice. And when they looked at treating them with chemo, cryo, or the combination, the lower bar on the left is the combination. And you see at around kind of 21 days is when the tumor starts growing again. So you kind of get a hit where the tumor volume decreases significantly, and the peak decrease is around 2 weeks, and then kind of stays low and then starts going back up around 3 weeks. And I think this is why when we treat patients within 3 weeks of each other, we're kind of decreasing the tumor volume and then stacking another decrease in the tumor volume on itself. Now, on the right side, the same mice, they looked at the timing of chemo and cryo, and they noticed that the most bang for your buck was within 24 or 48 hours. These were the 4 lines at the bottom. versus the untreated is the one on the top, and then chemo and cryo together more than 48 hours apart, or cryo alone were kind of similar in terms of volume kill or decrease in the volume of the tumor. Next slide. So I wanted to share some of the technical tips. I mean, I've been doing, I think, cryo for 14 years, and some of the things that we learned over time. So I shared how my technique to try to advance the scope to the distal end, and sometimes if I have to use the XP scope, I will. My preference would be to use the regular gastroscope, not the XP scope. I use both the CDD tube and the scope as a unit at the end. I do a lot of torquing to kind of find the space where the space is going to work the best. I spray distal to proximal. I don't see a reason why not do it the other way around. I find it a lot more reliable for my markings, and to spray distal to proximal. I typically spray 2 centimeters at a time, and it's kind of almost 180 degrees unless you have a very tight space where you end up spraying 360 degrees. But most of the times, if the space is not too tight, I kind of spray 2 centimeters at a time, 180 degrees. And then I start the timer when the area is completely white, not kind of flaky white. And I think that's probably when someone starts with this procedure, that's the area where they can get the most anxious. You want to start the timer before it's too late. This is when you look at the complication rate, and now we have very good data, prospective, with patients fall up rarely. This procedure, if done right, is pretty safe. This is why I'm a little less concerned about the adverse events. I'm more concerned about under-treating to get the response you want. And then Dr. Sharma stressed the importance of having a dry channel and also a dry camera for visibility. So I wipe the camera with alcohol because it dehydrates the space. And so after I go and clean, I take my scope out, I dry the channel, I wipe the camera with alcohol. And then what to do if you lose visibility, don't panic. Even if you can see a tiny space of the screen that's still visible and your scope is moving, I continue and finishing my spray. I defrost between sites routinely, and then I keep my finger on the CO2, but not on the water. If you spray water, you're going to kill your visibility all the time because that keeps spraying dry air over the lens and gives you better visibility. So anytime I'm spraying liquid nitrogen, I'm keeping my finger on the CO2 constantly. And I have all my nurse constantly monitor the abdomen. We've had a couple of situations where the suction wasn't working right, and then we learned about it from the nurse noticing that the abdomen was distended. So I feel that's an extra layer of safety. And I think that's it for me.
Thank you.
Thank you very much.
Dr. Shah. Dr. Shah, we talk about early esophageal cancer management with the case highlight. His research highlight will be changes in the microenvironment with liquid nitrogen spray therapy and chemoradiation in locally advanced esophageal cancer. Dr. Shah.
Well, thank you. So I'm going to shift gears a little bit and talk about the kind of patient that comes to us pretty often, who comes in with a bulky tumor, but you get a PET scan and you're staging and you find that they don't actually have any metastases. So that's the kind of patient that's probably going to get some preoperative systemic therapy, whether it's chemotherapy or chemotherapy and radiation, and then may end up being a surgical candidate. This is the kind of patient that may have a long-term survival. There's about a 40% 5-year survival rate, but there's a lot of room for growth. And so I think, we've done some work where we found that, cryo may have an important role in this group of patients, and also reinforce some of the things that Dr. Sharma and Dr. Kashami talked about. So next slide. So this is a pretty typical patient that I'm talking about. This was, I haven't included his age, but he was a 77-year-old gentleman. Came in with dysphagia to solids. He was tolerating really only pureed foods. And we really couldn't do too much of staging with EUS because the tumor was so bulky. He got a PET scan that didn't show any distant metastases. And so he was seen by our oncologists, our radiation oncologists and surgeons, and a plan was made for neoadjuvant chemoradiation and potentially with a plan to consider surgery afterwards. And so, the question I'll pose to the audience, somewhat similar to what Dr. Kashami posed, what would you do to palliate dysphagia before the patient starts chemoradiation? So A, would you do nothing? 2, would you do esophageal dilation? Would you place a feeding tube, whether it's a gastrostomy or a jejunostomy, an esophageal stent, or something else? All right, so it looks like, not surprising, a lot of folks have chosen esophageal stents, and a fair number have chosen really the gamut of things. All right, next slide. So do nothing is probably, the most common thing in clinical practice, right? We make the diagnosis. We might do an endoscopic ultrasound, stage the tumor, and say, okay, go follow up with your oncologist. But obviously, that doesn't help the patient, swallow before they get to chemoradiation, and may even delay chemoradiation. Esophageal dilation can be done. I have done dilation. But it's always a bit scary. There's certainly a real risk of perforation, although you can do it safely if you do it right. And the relief is really very temporary. And sometimes you don't really get any relief at all, even though you've done what seems to be a pretty scary dilation. Feeding tubes help with malnutrition, but particularly gastrostomy may not be preferable in somebody who with a potential plan for esophagectomy. And more important, if our goal is to palliate dysphagia and get the patient's quality of life to improve and get the patient to swallow better, you've really done nothing for that. Next slide. And so most of the audience chose esophageal stents, and that's not unreasonable. It's what I used to do when I first started practicing. The problem, as most of you who've done this in the neoadjuvant setting, is you place the stent, and then the patient starts chemoradiation, and then a few weeks later, you get that phone call, hey, we did an x-ray and the stent is in the stomach. And so you can say, well, maybe I can suture the stent, I can clip the stent, but really you still have at least a 40%, if not higher, migration rate. Another very common and distressing problem in this population is when you stent across the GE junction, you now have an open barrier between the stomach and the esophagus. And in particular, if they lay flat, you have a very high risk of aspiration pneumonia. I just had a couple, I still stent some patients in certain situations, and I just had a couple of cases of aspiration pneumonia. So this is a very real problem. I think there's chest pain and GERD, which can be managed. But what's really given me pause is several publications in which stents actually increase chemoradiation-related toxicity and may actually worsen survival. Again, these are retrospective studies, but they've really given me pause with regards to using esophageal stents in this setting. All right, next slide. And so the next question, obviously this is a cryo talk, is do you feel comfortable offering spray cryo before or during chemoradiation? So choice number 1 would be no way, I'm not doing that. I don't think it's safe. B, I'm not doing that because I don't think it's going to be effective. C, or 3, I might consider this, but I need to see a little more data. And number 4 is, yeah, I already feel comfortable with this. All right, well, I guess this is a cryo talk. Looks like nobody picked would not offer due to safety or effectiveness concerns. But we're pretty split between, well, we need to see more data or I feel comfortable already, which is great. So next slide. So that was where we were several years ago. We said, well, is cryo something we could do, before chemotherapy and radiation? And this was something that folks weren't doing. There was a lot of concern about doing cryo, particularly before radiation. There was a concern, well, you're going to cause tracheoesophageal fistulas. So we did a pilot prospective clinical trial. So we enrolled 21 patients. 14 had locally advanced cancer. 7 actually had metastatic cancer. And what we did was very simple. We just gave them 1 session of cryotherapy before they started neoadjuvant chemoradiation. And on average, we treated 2 sites each session, and we did about 4 ablations of 30 seconds each. This was a study that, we had some pilot funding from the ASGE, so I do want to kind of thank them for supporting this study. Next slide. And so what we found using the score that Dr. Kashami talked about, the dysphagia score, improved significantly in 70% of patients at 1 week. that number went down to 50% at 2 weeks. And I think Dr. Kashami talked a little bit about why that might be. Importantly, no patient required an esophageal stents. Really only 10% ended up requiring a J tube to supplement their nutrition during chemoradiation. And most importantly, there were no serious adverse events. Next slide. Now, one of the really interesting things that came out of this study is we looked at what percentage of patients had a complete clinical response and how many of them maintained it at 1 year after chemoradiation was completed. And what we found was that a long-term 1-year complete remission was achieved in 44% of patients who did not undergo surgery. We had a lot of patients who were in their 80s, not surgical candidates. So almost half of them were able to maintain a remission. When you look back at the original, the cross studies and the chemotherapy studies, what you find is you typically expect about a 25% remission rate. So at least in this small group of patients, we saw that our complete remission rates were a lot higher than anticipated. And so we hypothesized that maybe spray cryotherapy enhances immune-mediated cell death of esophageal tumor cells, and maybe it works synergistically with chemoradiation. Next slide. So what we then did is we said, well, let's take our patients in our study who got cryotherapy, chemotherapy, and radiation for whom we had pre and post tissue. And then let's look at a group of patients who are matched and who just got chemoradiation alone. And what we found was that 5-time increase in intratumoral T cells was seen in 40% of patients in the cryo chemotherapy group, only 25% in the chemoradiation group. A 5 times increase in cytotoxic T cells was seen in 60 versus 50%, so a slight increase in the cryo group. And the reason that was important was that patients who had a robust cytotoxic T cell response had a significantly longer survival. So these were data that we presented at ACG last year, and the manuscript's in press right now. Next slide. And so the next question would be, well, we have good data that you can give 1 session of cryotherapy. Can we give multiple sessions of cryotherapy? Because as I described, that 50% of the patients at 1 week, the significant improvement in dysphagia was seen in 70%, but by 2 weeks it went down to 50. So can you give more? So choice number 1 would be no. I wouldn't, do neoadjuvant cryo period. Choice number 2 would be maybe I'll do the 1 session since you've shown me that data. Choice number 3 would be I would certainly offer multiple sessions before chemoradiation, but not during chemoradiation. And the last one would you can give multiple sessions before and during chemoradiation. Well, looks like sort of you beat me to the punch. Well, maybe not quite, but so the last choice seems to be the most popular one. All right, next slide. So that really was the second question we sought to answer. We said, well, if we can give 1 session of cryo, and that's safe to do, and we think that 1 session, might improve the effectiveness of chemoradiation, well, how much can we give to maximize, really optimize quality of life and maybe this potential synergistic effect? So we said, let's sort of, design it like a phase 1 study. So we enrolled 3 patients to get 2 sessions of cryotherapy before they started chemoradiation. And there were some fairly complex dose escalation and de-escalation rules. But to kind of simplify it, we said, well, if those 3 patients did not have any grade 3 toxicity, we would then enroll 3 patients to get 3 sessions before and during chemoradiation. And then if there was no grade 3 toxicity for those 3 patients, we'd get another 3 patients and confirm that that dose was safe. So 2 sessions before chemoradiation and 1 during chemoradiation. Next slide. So what we found was that no patient had grade 2 or 3 toxicity. When we called patients, again, this wasn't things that they were calling us for, but because this was a clinical trial, we were calling them. About 50% did report self-limited chest discomfort. So I think it's something that I will talk to patients about. Certainly nothing close to what I get with RFA, but it is something with bulky tumors that they can experience. But importantly, no patient had to delay or discontinue chemoradiation because of a cryo-related reason. Next slide. In terms of quality of life, I actually used the same scores that Dr. Kashami talked about, the Mello-Pincus dysphagia score and the EORTC, and both significantly improved 1 week after each session before chemoradiation. Now, that session we gave during chemoradiation, although there were no toxicities, we found that dysphagia and quality of life did not improve significantly when we gave cryo. And so it seemed to us that the most bang for the buck was when you gave it beforehand. Again, very similar to our prior study. Last slide. Only 2 patients required a feeding tube and no patients got an esophageal stent. Next slide. And then going back to that whole idea about survival and immune response, so very consistent with our prior study, about 50% of patients had a complete clinical response after chemoradiation. And then what we did was we measured this protein HMGB1, and what we found was that over 25% had, or actually about 40% of the patients had a greater than 25% decrease in HMGB1. So HMGB1 acts on toll-like receptors to present antigens from dying tumor cells. And the importance is in multiple studies, HMGB1 correlates inversely with response to anti-cancer immunotherapy. So having a decrease with cryo means you're more likely to respond to anti-cancer therapy. Next slide. So to summarize, spray cryotherapy may be safer than other available modalities to palliate dysphagia prior to neoadjuvant chemoradiation. So specifically, it's probably safer and more effective than dilation. It certainly is safer and has a much better toxicity profile than stents. Spray cryotherapy improves dysphagia and quality of life before chemoradiation. And early observations suggest that spray cryotherapy may enhance anti-tumor immune response, may increase the effectiveness of chemoradiation. But I think what we need to really look at, I think the next group of studies I'd like to do is not everybody has the same response. Some people have the spectacular response and seem to live a lot longer, and some people don't respond a whole lot. So I think there is some degree of identifying which patients really benefit in terms of this immune response. Next slide. Just a couple of practical suggestions if you're gonna do cryotherapy in the neoadjuvant setting. So just to minimize inconvenience and the number of procedures for the patient, I like to do my first session at the time of the initial staging EUS, so that would be 0 weeks. I used to do this every 2 weeks apart, but now that we have data from Dr. Kashami's study, I think the best way to do it is to really do the first session during staging EUS, bring him back in a week and bring him back at 2 weeks so that they get 3 sessions before they start chemoradiation. And again, looking at our data, it's safe to give cryo during chemoradiation, but it didn't, I think at that point, patients are just having such a hard time with all the radiation esophagitis that maybe the juice is not worth the squeeze during radiation therapy. So I think the best way to do it is 3 sessions before you start chemoradiation. Next slide. And so just a few, I think some of these have been touched on already, but I think it's particularly relevant when we're talking about bulky tumors. So in general, it's safe to dilate up to 15 millimeters to allow passage of the decompression tube and gastroscope. But obviously what I'm talking about is that patient where you can get the decompression tube down and you can kind of get your gastroscope down, but you just are having that little bit of trouble, passing both through. That's the kind of patient that it may be safe to dilate. Obviously, if you can barely get your decompression tube down, you don't want to try this. Really, cryo is probably not going to be a good option in that group of patients. In this group of patients, because you're trying to just minimize, all the bulk of the equipment, consider not using a distal cap. And the last, again, Dr. Kashami touched on, and really it's something that, he taught me, and I've had to incorporate a lot into my clinical practice, is that you can fit a catheter through a pediatric XP190 Olympus gastroscope, which is 5.5 millimeters in diameter, because it does have a 2.2 millimeter working channel. Again, you sacrifice a little bit of sort of movability and maneuverability, but at least it allows you to do your procedure. And I believe that's all I have.
Thank you so much. There's a couple of questions, but we're getting a little behind on time. So I want to leave time for our last speaker tonight, Dr. Vargo, who's going to talk about a squamous cell carcinoma case that highlights the use of spray cryoablation as salvage therapy, and then go through our pearls and key takeaways for everyone. Dr. Vargo.
Thanks, Neil, and thanks for the honor to present. Next slide, please. So this is a gentleman that I actually just treated a couple months ago, which I really think is apropos for this presentation. 76-year-old gentleman. He had a history of a T1B squamous in the proximal esophagus. He underwent ESD with some adjuvant radiotherapy back in 2017. Was seeing my partner and said, you know, I'm having trouble swallowing again, and that prompted some evaluation. Next slide. So I talked about this. He had a big wide margin ESD, 6 centimeters in length, proximal esophagus. Next slide. Again, he had ESD with adjuvant XRT. Next slide. And the thing about this gentleman was, when I was really struck when I saw him in clinic, he really had orthodeoxia. He's tachypnic. He had very significant COPD. He's also essentially a vasculopath with type 3 chronic kidney disease and a host of other comorbidities. So a gentleman who was very interested in having us treat his dysphagia, but obviously this is going to be a challenge. This gentleman is very ill. Next slide. So what you can see in the picture is this is just past the cricopharyngeus at about 18. We've got this linear ulcerated but primarily submucosal mass, and this was found to be a second squamous cell cancer. So next slide. We got a PET scan, and predictably it was hot right where this area was. CT scan really didn't show much going on, wall thickening, et cetera, but really non-specific. Next slide. So we presented him to our tumor board, and it basically was crickets. They all turned and said, "Where's Vargo? It's time to do some cryotherapy." So we spoke. I mean, he even went to see surgeons, and the surgeon would say, "Well, if I had to, but this is so proximal, they were going to have to do a laryngectomy on this guy." So I mean, just ugh. So it was cryo or nothing. So we had a nice discussion, and we decided to go forward with that. Next slide. So here's our little question. How would you address the airway in this situation, given the proximal location of the tumor? Would you use high flow nasal oxygen, endotracheal intubation, a palm mask, or let's just do what I always do with some nasal cannula oxygen? That's our question. Yeah, that's exactly what we decided to do. I felt very uncomfortable. This is very proximal. This gentleman had significant COPD, so we definitely wanted to protect the airway. Passing the scope, having the suction catheter really isn't that big of a problem, as our other two lectures have told you. If you had something inside the esophagus, like a tumor, that would be blocking. So next slide. So here's our slide. Now, the first thing I want to do is can we stop it just for a minute, Neil? I'm sorry. I'm going to preach focal length. Okay. It's all about, if you are moving the catheter in and out, this is not a good thing. You want to get this set with respect to your cap. You want to do as Dr. Kashami and Dr. Shah have told us, as well as Dr. Sharma. It's really taking your hand on the insertion scope and doing your movement with that. You should really keep this catheter to cap distance steady and move that way. Dr. Sharma talked about cupping. I call it half piping because of snowboarding. So that's obviously for when you're doing a 360. This is a little bit different because it's a focal target. So I'm actually going to use this cap to press into the tumor and take a tangential approach and make it almost end on. And you see this all the time when you use a cap. So let's, Neil, can you do that video? So we'll start this. just as Dr. Kashami has spoke about, I'm not timing you now. I'm not timing you now. Yes, start the timer. Don't start it early. And you're going to see I'm going to work up and down this area. Remember, it's about 2 centimeters in size. We got nice view here. Another little tip is take some practice runs before you start delivering your cryogen. So you got a kind of a feel for how that's going to work around the suction tube if it is a 360. So I'm just going to show this again. We got nice view here. We've done our 60-second thaw. We're going to do it again. We're going to let it go. No, don't start timing yet. No. Yeah, okay. This is what I want to see. I want to see a real robust cryogen effect. We got a nice hit here. I mean, we're all over this. We got a beautiful view here. So we're just, putting it right, the pedal to the metal here in terms of getting it cryoed. So in this case, you're going to see it hit again. And another effect you'll see as you accumulate, you're going to see your cryo effect a lot earlier with your subsequent cycles. And that's what you're really seeing here. In this case, we used 3 30-second cryogen applications with intercalated 60-second thaws. Okay, we can stop the video and let's go to the next slide. So there it is. This is about, I think, 6 weeks afterwards. You'll see a little whitish nubbin at 3 o'clock, and that's all that's left of that area. Dysphagia is better. Family's very happy. We didn't put him through a lot of risk. He didn't have to go, doesn't have to worry about undergoing a very radical and morbid surgery. So next slide. So he's doing well, no dysphagia or chest pain. I'll see him again in 10 to 12 weeks. And then, basically from here, I'll just follow his symptoms. If he starts having recurrent dysphagia, we'll take another look. Next slide. So again, 76-year-old male with metachronous squame, high-grade dysplasia due to multiple comorbidities, submucosal invasion. It was treated with cryotherapy with really a great response. Next slide. So one of the areas, I mean, the 2 speakers just before me are really, and as well as Dr. Sharma, Jedi masters of the whole issue in terms of advanced disease. Here are some of the studies that are out there, and I really look forward to a TUFIX study coming out because I think it's really going to add greatly to the literature. This is 88 patients, and it had a rather rigorous outcome, which was a complete tumor eradication or until there was advancing of the tumor despite therapy. So it's a very rigorous outcome. And what you can really see here is that predictably, the smaller tumors, at least in this study, did better than the ones that were a little more advanced. And you can see you got a very nice complete response of 55.8%. Now, the caveat here is that the dosimetry is not going to be the dosimetry that TLOC and TUFIC have talked about. This is a little more of an aggressive one that they have really been leading the way in terms of evidence basis for this more aggressive dosimetry. Next slide. And we talk about stents. Now, I got a thing on the wall here about the Schneider wall stent. So I was putting those in before pretty much all the people on this phone call were in high school. But let me tell you, there's morbidity with stents, and we talked about migration. We talked about pain, particularly in patients that have had radiation therapy. The other thing is, the GE junction's a really funny area because you can really jail the distal part of the stent against the greater curve, and you can get in a whole world of hurt with that. So this is a study that really looking at 56 patients, and this is a Kaplan-Meier curve looking at the patient survival without palliative stenting. And I would say a 0.6 is a pretty robust outcome with cryotherapy where people didn't need stents, undergoing the migration, the pain and blockage and things of this nature. So I think that there's some really good evidence to show that palliation of advanced esophageal cancer really has cryotherapy really has a role. Next slide. So conclusion, endoscopic cryotherapy can be a safe, well-tolerated, efficacious option for the treatment of early esophageal cancer in selected patients who are not candidates for conventional therapy. Next slide. So in conclusion, I've had the pleasure of just collating all. Oh, is this another? We have another. Okay. You see this list here. This poll question is, which of these potential applications are really not a potential application for liquid nitrogen cryoablation? High-risk anticoagulation patients, salvage ablation in those who may have failed RFA, adjuvant treatment post-EMR with high-grade dysplasia and early esophageal cancer, treatment of residual Barrett's after treatment of esophageal adeno, palliation of dysphagia, salvation treatment for local esophageal adeno and squame, add to neoadjuvant and definitive treatment paradigm, or TE fistula. So of these choices, which would not be a potential application of cryoablation? So we got a lot of answers here, but probably the one you want to think about is TE fistula. That could be a literal and figurative high pressure situation with nitrogen being introduced into the trachea. So that'd be one area that you'd want to be careful of. So we look at this list, if we can close that and we can go over this. An area that I was really excited and really got me, I've been in cryo for a long time, but really I had a few patients that actually had anterior wall MIs and had LAD stents put in. And there's no way you're going to take those patients off dual antiplatelet therapy. I also have a host of patients that have inherited hypercoagulable states, factor V Leiden with PEs and things of this nature. Cryo, it just fills this niche so ably. I think our lectures have also really shown that salvage ablation, adjuvant treatment of residual Barrett's, palliation of dysphagia, and salvage treatment, as well as the addition to neoadjuvant, are all reasonable areas of indications for cryotherapy. So with that, I'll just close my presentation and give it back to Neil. Thank you so much.
All right. Thank you, everyone. First and foremost, before we get into some questions, you can reach out to any of the brilliant speakers tonight. Here's everyone's emails, my own included. Actually, it's a little bit off. It's nrsharma219@yahoo.com. And feel free to reach out to any of us. I think we're all very approachable and would love to answer any questions you may have. Speaking of which, there have been a couple of specific questions that have popped up, and I'll probably try to target them relevant to what people spoke about. So one question that popped up is, are you worried more about stricturing in cases where you're giving chemotherapy and radiation? I think this is really well demonstrated by Dr. Shah, who intentionally studied this aspect. Dr. Shah, do you want to talk about that question?
Yeah, we, at least in our group of patients, we did not find strictures to be an issue. I think the biggest concern I had was if we're doing cryo and radiation, are we going to develop ulcers and TE fistulas, or deep ulcers and TE fistulas? And thankfully that didn't seem to be the case. But I think that's where I have seen folks, who've gotten chemotherapy and radiation and cryo, and whether it's related to the treatment or not, like at the end of everything, when they're going for surgery, you see these deep ulcers, and usually that's related to the chemoradiation itself. But that's a group of patients that I'd be a little bit hesitant to add on more cryo to. But the stricturing itself did not seem to be a big issue for us. In fact, the lumens seemed to open up, if anything.
And I believe you talked about this, but part of that question was dosimetry changes. You actually upregulated or dose escalated that during your study, as you pointed out.
Yeah, it was really the dose frequency escalation. So our dosimetry remained pretty steady. We tried to go, 30-second ablations, 45 to 60-second thaws. Tried our best to at least get 2 sites. So we were really trying to do the same thing between sessions as much as possible. As anyone who knows, who does, cryo knows, sometimes what guides how much cryo you can do is less. It's tough to be, very sort of, rigid about how much dosimetry you're going to do, because it's guided a little bit by your visualization and things of that nature.
Excellent. Another question that popped up is, can cryoablation or cryotherapy be used as a primary and only modality for long segment Barrett's with low-grade dysplasia? I think any of you are welcome to answer it. I know I've had experience with this as well. So any takers on that? So I've utilized it, and I think it's exactly what Dr. Vargo pointed out. Some of our patients just cannot come off of dual therapy or really aggressive therapy. And if you look at the package insert for RFA, you're technically supposed to take them off of even aspirin. So that's a great population where we've actually treated patients with low-grade dysplasia and put them into remission. I think one thing to point out is RFA obviously has 10 years worth of data. My mentor, I mentioned, Nick Shaheen, has published robust data to New England Journal. So typically people go for that, and it's an easier modality if you don't have any experience. But we've shown there's really an application here for utilizing it as primary therapy in low-grade Barrett's. Another question that's popped up here is, how far below the tip of the catheter is adequately frozen? In other words, if you have a narrow lumen, how far does that treatment go down? Thoughts, Dr. Kachami?
I mean, there's in science there, it's more experience. Let's say 2 centimeters. We do see the area sometimes. If you're freezing, you'll see, as you saw Dr. Vargo's video, you'll see more than 2 centimeters freeze. But are you getting that deep freeze that's gonna lead to the tissue death? I'm not so sure. I'd say 2 to 3 centimeters would be max.
Okay. Other thoughts on that?
No, but I want to go back to the previous question on low-grade dysplasia. And I have to say, several years ago, one of my colleagues, George Smallfield, published a prospective study where they looked at pain scores between RFA and cryo. And one of the things they found, and I think it's been a lot of our clinical practices, there's a lot less chest pain with cryo than RFA. So for me, in Barrett's and low-grade dysplasia, I think RFA tends to be my first line, but where things branch off is if there's like multifocal, high-grade dysplasia or cancer or nodular stuff. But the other more common reason tends to be when I start getting that phone call for chest pain, I say, how about we switch you to cryo the next time? And they seem to tolerate that a whole lot better.
Tilak, I just got to mirror that. You got a Prague C10 M12, and you're going to try to RFA. You're going to get some phone calls. I've been really struck by the lack of chest pain with cryo. The other thing is RFA is not a panacea. You take somebody with a dilated esophagus where the 360s just banging around in the, you got cases now, 5 centimeter hiatal hernias, patients who can't tolerate PPIs, gastroparesis. There's a whole host of these patients that where just RFA isn't it. And you want to talk about dosimetry variants, trying to use a Halo 60 or 90. You've lost all that dosimetry. So there's a whole host of patients that are really primed for the approach with cryotherapy.
Dr. Vargo, there's a specific question to the case that you highlighted. It's very proximal in the esophagus where you eloquently demonstrated the treatment of a squamous cell carcinoma. So there's an experienced user who I know is asking a question relevant to proximity to the UES. So the question essentially says, the issue here seems to be how to best position the catheter to visualize the treatment so close to the UES. And the user is wondering if, in some cases, the ET tube might not allow for flexibility at the esophageal inlet to properly position the scope and catheter.
Yeah.
In this case, it worked, but using high flow nasal might be better in some other patients. What are your thoughts around that?
That's a great question. A good hypothesis generator for this. Certainly, you could make a point to use the high flow. One of the things I always concerned about is saliva. And my nitrogen taking the saliva up and around things a little bit. So that's the other variable here. I got really lucky. It almost was like I was kind of going through a pylorus and trying to treat something in the bulb just past the pylorus. But that's where a nice cap can set you up. And we didn't talk a lot about cap length, but sometimes you can change your cap length. It's almost like hitting a golf club. You want to get extra distance. Sometimes you want to take that cap and make it a little bit longer so you can do that angulation a little bit. But that's a good point. We could have done the high flow oxygen and in that case too. But given this gentleman's COPD, I mean, honestly, he had orthodeoxia and was tachypnic in my office. And I'm supposed to put this guy to sleep. It's like, so I really kind of bagged it and said, listen, let's just go with the ET tube and just call it a day. But a great point. Maybe somebody with a more of a vital capacity, maybe I would have considered it. Good point.
Another question relevant to that from the user who's asking the question here is relevant to the distal tip of the catheter. So you talked about focal length. They note that you actually put the tip of the catheter just inside the cap in your case.
Right.
Is that your standard approach is the question? The other part of that question is, do you do this at a specific patient, like in this case scenario where you chose to put it just inside?
That's a good question. If I'm treating something flat, I usually have it out peeking out of the cap a little bit. For this, if you noticed, I kind of turned into it first to really get a good hit with it. So I did. If I kept it out, I would have buried it. And it's sort of like APC. When it starts sticking, you lose style points. And so I kept it in a little bit so I could actually bend into the tumor and have it a little more on FOSS when I started. If you notice that, it didn't work as well as I worked down it, but I just wanted to make sure I got that proximal edge because it was bigger. The tumor was bigger more proximally. So I really wanted to make sure I got a good effect on that proximal aspect.
Excellent. And relevant to that Barrett's question, there has been some data that's been put out by Dr. Call's group, and that was about using actually cryo as a primary therapy, both for Barrett's as well as early esophageal neoplasia. So there is some other data as well as Dr. Smallfield's data. There was a question from an anonymous attendee relevant to optimal timing for tumor shrinkage, 2 to 3 weeks between cryo treatments. How does that fit with stricture or severe ulceration or incomplete healing between the sessions? Because Dr. Kachami, you're probably the right person here. You talked about aggressive dosimetry, so essentially reducing the interval between treatments. Thoughts about that?
Absolutely. These are bulky.
Welcome to Dragon Medical One. You're now one of over 500,000 clinicians worldwide, dictating Dragon Medical One to capture the complete patient story.
Am I the only one hearing this?
Dragon Medical One saves you up to 2 hours a day and reduces documentation time by 50%. With the time you save, you can get back to what's important, like dinner with your family, walk in the woods with a friend.
Sorry, not sure where it's coming from.
Yeah, apologies about this. So these are, to answer the question, any concern about incomplete healing, tumors don't really heal. And these are bulky tumors. I mean, I think of it as you're shaving off, let's say, 2 to 3 millimeters from the tumor, and then another week later, you're shaving off 2 to 3 millimeters. The esophagus diameter, 2 by 3 centimeters, once it's nearly obstructed with tumor, you're talking about a bulky tumor that's, at least probably 10 millimeters in diameter. So I think it's fine. When I've done it, very quickly, let's say 4 days or 3 days after, you can see kind of a white rim on top, which is probably necrotic tissue. If you remember the days of photodynamic therapy, they used to treat on Wednesday and Friday, and they used to shave off that. So really, in the past, when we tried to palliate dysphagia in patients with esophageal cancer, we were more aggressive than we are now. And photodynamic therapy has a lot more adverse events and is less well tolerated. So I think with therapy like this, that's better tolerated. We haven't had problems with more intensive treatment.
Yeah, one of the things I found, the challenge we had was when we first started, especially when I started using Tufek's approach of trying to do it every week, was finding spots on the schedule. And so just some of the practical issues that came up. And so what we started doing, and I'm sure most of you are already doing this, is we just started pre-booking their like 3 sessions up front so that they already had it booked. Because otherwise, if I didn't do that, I found that it became a nightmare logistically.
You don't quadruple book?
Quadruple? No, I haven't quadruple, but I have triple booked.
Relevant to what you talked about, which I thought was really interesting about utilizing it in adjunct to chemotherapy and chemorads. 2 questions. One was cryo balloon with nitrous oxide, would you get the same results with the cryo balloon with nitrous oxide, Dr. Shah?
It's interesting when we were first started thinking about this question, because the idea was, can ablation, some ablative modality, improve dysphagia and improve immune response? So the problems that came up with RFA were it's too superficial for a bulky tumor. The problem with cryoballoon was that the balloon senses pressure. So it would start, when we tried to play with it, you couldn't get it to work in a bulky tumor. And depth of penetration is again going to be an issue. So really, we weren't really left with, the modalities that were possible options were really cryo and APC. And for a variety of reasons, we felt that cryo would have a better sort of, and again, had better data in this area. So long answer short, long story short, no, you really can't use the cryo balloon. Cryo balloon is a reasonable option for Barrett's, but not for bulky tumors.
Yeah, I would agree. I would echo that. So just think about the modality of cryo balloon. And we played around with this pretty early on esophageal cancer, and it failed pretty quickly. So its depth of penetration is going to be limited. It's easier to use as a user because you press a button and it goes in a circle and it delivers this amount. But it's not spraying. You can't manipulate the dosimetry the way we talked about tonight to get to bulky esophageal cancers. I would argue that potentially its depth of penetration is different as well. So probably not applicable for esophageal cancers in any modality relevant to that. The second part that's also part of this that was probably asked, I would assume maybe by a medical oncologist, which is a really great question. Node positivity is an independent prognosticator in esophageal adenocarcinoma. Wouldn't delaying systemic therapy in the neoadjuvant setting compromise the outcomes? So this is again looking at your trial, and did you delay some chemotherapy radiation?
No, we actually didn't. So and that was the idea when we did our initial study, we did the cryo, and that was exactly the idea, was not to delay chemoradiation. So when we did the initial study, we did the cryo during the staging EUS. So there was really no delay in treatment. I was initially at the VA, and our time to start therapy was a little bit slower, it was maybe, a little over 3 to 4 weeks. So when we did it every 2 weeks apart, again, there wasn't a delay. And now if we're talking about Dr. Kashami's approach, incorporating that where we do it at 0, 1, and 2 weeks, that's really not much of a delay. So the idea, it's absolutely right. We don't want to delay systemic chemoradiation. And if we do it right, we do it aggressively, you end up not delaying chemoradiation.
Yeah, excellent. Dr. Varga?
Talak, what's really cool is the fact that protein that you sensed, was that systemic, or was it, yeah. So you actually may actually be helping the lymph nodes because you're affecting that toll protein. So actually the answer could be it could help actually affect the lymph nodes because of that modulation of that protein. I found that fascinating.
Dr. Varga, a question for you. I think this is a question that our fellows will ask me, our advanced fellow, when they're first, if they've never done cryo, never seen it before. Are there endoscopic signs of wall integrity that might make you pause when you're treating with cryoablation, that might make you stop from cryoing a patient? Either during the procedure or maybe even before you go down, you see something. There's something that makes you pause on cryoablation?
That's a really good question. I would have to defer somewhat to my colleagues here on the call in terms of ulcerated tumors and things of this nature. I think the data would say, at least in those conditions, you're not seeing that pneumodissection that we all are concerned about. I would probably, that's a really good question. I think I would kind of be concerned about somebody who was immunocompetent, maybe with a low platelet count, and may have had like a viral esophagitis or something of that nature. I'd be a little concerned, but I can't think of anything else in terms of wall. That's a great question, but I can't think of anything else in wall integrity that I would be that would give me pause at that point. I guess that's the best way I can craft that answer, Neil.
Yeah, perfect. Well, let's go around the circle. Anything, Dr. Kashami, that you might see that might give you a pause?
No, I mean, I agree with Dr. Varga. Like if someone has Candida esophagitis, which can happen, I usually don't treat them. We know, for example, Candida esophagitis is a systemic disease, so I don't know how deep the wall is affected. So I usually will treat their candida and bring them back for cryotherapy. Ulcerations do not bother me at all. I mean, tumors are always going to be ulcerated. I think Dr. Shah showed us the picture of the tumor that he treated. I mean, tumors are ulcerated by definition. And what we are seeing is the ulceration on the surface of a bulky mass. So underneath is just more tumor.
Yeah. Dr. Shah, anything that makes you pause endoscopically, any signs?
Yeah, I mean, so there's ulcers, and then there's those ulcers that look like they're close to eroding into the mediastinum ulcers, and we all certainly see those, and those are where I sort of I can't say that I'm not going to do a trial on that, but I worry like you're ablating an ulcer and not like something that's occluding the lumen. But that's where I worry about, basically causing a TE fistula. So if I see a very deep ulcer, that ulcer sort of looking necrotic, that's one area where that's one group of patients that occasionally I've sort of avoided that area in cryo. The rest is to get the patient, swallowing better, but it does give me some pause.
I have a little pause with adenocarcinoma. We treated lots and lots of patients, but I think with squames, they, especially the proximal squames, if they look deeply ulcerated, I'd be very cautious. As you guys have all probably seen, they are TE fistulas, and they usually are squamous cell carcinomas that fistulize. So that would be probably the one thing that I would look out for. Something proximal, kind of at the level of the trachea or the carina, so around that 20 to 25 range, and it looks deeply ulcerated. I would just be thoughtful about that. There was a question relevant to taking biopsies and dilating, and one specific on a cryoablation patient who has had esophageal adenocarcinoma, has had chemoradiation, still dysphagia, but no visible tumor, but there's narrowing from stricturing. Can we do cryo on those patients? So there is one set of data that came from Jason Samarcina, and it looked at utilizing cryoablation followed by dilation in patients with benign or malignant esophageal strictures, particularly focused on benign for him. I do think that you can dilate after you do cryoablation, and sometimes that the tissue is even more responsive to dilation afterwards. So definitely that's something that I will routinely offer patients, especially even when they have really bulky tumors. And I've seen no issues or complications, but just thoughts from others?
I think if I've not seen tumor at the end of chemoradiation, I've called that a win, and just done dilation. It's at least it hasn't, unless I see visible tumor, it hasn't been my practice to do cryoablation. But if somebody publishes something that shows that that's a valuable approach, I'd be very interested. It's something we could look at.
Yeah. I could take it from the other spectrum. I mean, I think Neil brought this up. I'm not going to talk about tumor. I'm going to talk about flat Barrett's. It's the best time in the world to do biopsies after cryo because the pathologists can't tell the difference. So you can actually do your surveillance biopsies, leave the cap on, turn right in and just do your biopsies. And they'll say, it's kind of nice. Do you got a CRIM or do you got a CRID? You can do that after you do your therapy, and your pathologist will never know the difference. It's kind of fun to see that.
So pre-cryo, you can definitely do biopsies. Actually, our study protocol, because we were collecting tissue, was to collect tissue and then do cryo. So I mean, we did it as part of our protocol, and there were no adverse events.
Well, guys, we are now almost 40 minutes over. We still have surprisingly 64 people on, but I think it's probably time for us to call it an evening. I've been really, really lucky to have 3 people that I consider not just experts, but friends and people that I enjoy listening to speak, and I could hear you guys speak all night. So thank you for participating in this talk. Thank you to Stairs for sponsoring the talk and EndoscopyNow as well. This will be recorded. It's usually rebroadcast and available on EndoscopyNow for future viewing. Whitney, I'll turn it back to you.
Thanks, Dr. Sharma, and thank you, everyone. This concludes today's discussion and Q&A. Thank you for joining us, and have a great evening. Bye-bye.